Good morning, everyone. I want to thank everyone for coming this morning. I appreciate your attendance. It'll be, I think, a relatively small group, but at the same time, there'll be plenty of drop-ins. The word has been sent out to folks over on the hospital side also, so I imagine their schedules are pretty busy. But again, thank you so much for coming. This is going to be somewhat of a unique experience, and we'll go into a little more detail later in the sequence of talks, but there's going to be a lot of patient interaction here. We have a number of excellent speakers that have some unique perspectives, but at the same time, we have some very highly educated patients that are here also to communicate their experience. And so I think that's going to be unique and pretty exciting. Certainly something that will be following the conclusion of this meeting, digesting for several weeks in preparation for aHUS Awareness Day. So recognize that all of this is being recorded, both video and audio, in preparation for September 24th, which is identified as aHUS Awareness Day globally. And at that point, hopefully all of the video and audio will be edited appropriately, and we'll be able to broadcast that across the internet at that point. So just to somewhat keep on time here, a few housekeeping points. If you haven't registered for this symposium already, if you could even retrospectively, that'd be great, just so that we can have a tally in that regard. This is going to be a pretty compact meeting in the sense that there's going to be lunches provided at about 12:15 or so, but we're just going to keep on moving through with the talks. So recognize that there's going to be some coffee breaks and times to mingle throughout the day, but they're not going to be for more than 10 minutes or so. So there's going to be food provided, but at the same time, it's really going to be a rolling schedule in that regard. Most of you, I think, are familiar with the area, but bathrooms are out at the back of the hallway off to the left-hand side as you exit. The schedule will finish about 4:15, 4:20 or so, but we'll try to keep the room open as long as possible, just so that people can continue to interact and kind of dialogue based on what they experienced today. So all of that being said, I'd like to introduce to you next Dr. Joseph Bonventre. He's the chief of the renal division here at the Brigham and Women's Hospital. He's also the Samuel Levine Professor of Medicine at the Harvard Medical School, and has been very helpful in providing an environment such that something like this can occur. Recognize that this is not an event that is sponsored by HMS or by the Brigham and Women's Hospital, but at the same time, that the intentions are recognized that it's something that we need to continue to develop.
I just want to extend my welcome. You're on our turf here, and as such, I'm very pleased that we have this opportunity. The Alliance has been very important for patients, and also extending awareness to the entire community, including the biotechnology, pharmacology, pharmaceutical community and academic community, putting a focus on the endothelium, which I think is an underserved part of the kidney for therapeutic direction and targeting. So I think, from the perspective of this symposium, you're going to hear, as has been stated, a good deal from patients, and patients are playing a much greater role in helping to define the research agenda. Frequently in the past, I would get asked from a biotechnology community, well, how important is itching to patients? And because they're thinking about, in another context, as an example. And to some extent, it's hard to know how important. But the reason it's hard to know is because there haven't been patient groups that have come together and defined what it is about the disease that they're most concerned about. We as academics, as scientists, we know what we're thinking about is really important, but the patient input is something that's being recognized more and more in national fora at the NIH, and it's not unusual now for patients to be asked to have a direct impact on the research agenda. So that's part of what we're talking about here, and beyond research is obviously diagnostic agenda. And so I'm sure there's going to be a lot of interesting things transmitted in that context. The other thing is that as sort of a theme, the patient input being one, but the other theme is collaboration. And as we, in particular in rare diseases, which present in sort of their own particular way, it's very important to be alert to those diseases at an early stage, and I know there'll be discussions about that, and that's another important aspect. And also, the last thing I would just say is that, you know, it's actually very, very well titled in thrombotic microangiopathy through the lens of atypical HUS, and really, with atypical HUS, that's one presentation that may really be the tip of the iceberg. There's a lot of other things that are going on in the endothelium that maybe we're just not recognizing, but that are playing a role that are not quite as dramatic or as acute as we see with atypical HUS, but are nevertheless you know, important to think about and to relate one to another so that we can get the therapeutic engines focused in those areas. So Linda and Andrew in particular playing a major role in this, and so I look forward to a very lively discussion. Unfortunately, I'm going to have to be in and out because of other responsibilities, but have a great session. So, thank you.
Thanks, Joe. So next we'll be having Mr. Len Woodward give an introduction here. This is certainly a patient perspective, and he'll be able to tell you much more about what's developing on that side.
Thank you very much. Right. Well, first of all, I'd like to thank you all for coming and welcome you to this symposium on behalf of the aHUS Alliance. For those of you who are not familiar with the aHUS Alliance, it began about 4.5 years ago when 6 European aHUS patient organisations gathered together and and thought that there were some things that they were better doing together in a collaboration than working alone, and that became the essence of what the Alliance was about. Since then, we've now got 12 nation patient organisations actively participating in the aHUS Alliance, plus we know about another 12 patient organisations who are in an embryonic stage of development as patient advocates, and we have sort of helped them to form basically individual patient advocacy, and they're developing into their own groups. In fact, this morning I received an email from Poland who are now ready to create a patient organisation in Poland advocating on behalf of young people and children in Poland. So that's coincidental. So yeah, developing advocacy amongst other countries is a key part of our mission. And to facilitate that development, we have got a aHUS Rest of World organisation to take these individuals and develop them into advocates, group advocates. The other part of our stated mission is to support research, and that was a key element, and as part of that we have, as the aHUS Alliance, participated in the KDIGO controversy conference a couple of years back in and we had a representative there representing the aHUS Alliance. We're part of that. Also, we are part of the global aHUS registry as patient representation and active participants in that, in that we have set an agenda for the program of that registry as the way they now program and prioritize the research that they're going to do as part of the registry. And that has now developed into a patient agenda. We taken in information from a video that we created for Rare Disease Day this year, and we got 80-odd patients from around 17 countries, I think it was, giving us questions that they thought were important to them. And we've taken them, added to the stuff that we put into the aHUS registry, and we've now got this massive agenda that anybody asks us what's important to patients with aHUS, we can tell them because we've got the answers. The other thing is the raising awareness, and we are becoming known, and aHUS is becoming known, and we have a website. That's a key part of our awareness creation, and social media. And Linda's tweeting away at the back of the room here. We use the social media to get the message out about aHUS, Facebook, and so on. And we also have aHUS Awareness Day, which has already been mentioned. Once a year in September, we focus on the disease. aHUS, like all rare diseases, faces challenges. Information is a key challenge, and I think we have, to some extent, over the last 10 years, provided a lot more information to patients than we ever used to do. So that's not a bad thing for us as a rare disease. And also, research and registries. There's an enormous amount of research been undertaken in the last 20 years on aHUS. And there's a lot of registries, not just the global registry, but in individual countries, there's big registries. And finally, the expert centres, they're cropping up all over the world, and they're talking to each other as well, so that's excellent for a rare disease perspective. And finally, treatment. We have, well, first of all, Eygenraam, but also there's other developments taking place. So the 2020s look promising for aHUS patients globally. But diagnosis remains a challenge. There are still people dying from and going into kidney failure with aHUS. It is the challenge. And for that, the solution is obviously blood tests, that needs to be better done to identify an aHUS patient. It's unrealistic for all doctors to know about aHUS. It's such an ultra-rare disease. So it's when patients or patient organisations are now thinking is, well, the key thing is identifying, first of all, acute kidney injury. That gets you somewhere, and then thinking about TMA, because it may be the cause of the acute kidney injury. And once you've got to that point, then there's a few more steps and you're at aHUS. And so it's important that people think AKI, think TMA, then think aHUS. And pivotal to that is the quick identification of thrombotic microangiopathy. That's how we see it now. And hopefully this symposium will help with creating that awareness, and that's what today is about.
If you could, for just a minute, could you talk about the previous events that you all, as a part of the aHUS Alliance, have put together? Because there's a heritage here. I mean, I'm not sure. When I first approached you, I didn't recognize that this had been done in similar formats previously. But could you just say a word about that, UK and in Iowa?
Yeah, well, Iowa has been going on for longer than I think Linda knows more about this, but that's an expert centre in the USA. And every 2 years there's a conference about aHUS there, and that's an excellent, I've attended it in fact, and it was an excellent conference. I took the ideas away from Iowa, and we had a conference in the UK, which was led by Tim Goodship, which some of you may know about. We had a session about aHUS, and if you've got one of the folders outside, it was built around that Tim Goodship's Venn diagram of predisposition, triggering factors, and other genetic condition causes. So that came out of the visit to Iowa. I think France have done 2, maybe 3 aHUS patient conferences, and I'm not sure where the others, where they're up to, but the first aHUS patient conference, and that was an experience that a lot of aHUS patients have met since. It was in England, was in Newcastle upon Tyne, and Emma and I, my daughter, went to the conference, and we were gobsmacked. There were so many people with the disease because we'd never met anybody with aHUS before, and that was the same reaction from the other patients. So, yeah, these gatherings for aHUS patients are important, but I think this is unique in that it's linking more with the TMA aspect, and although there are TMA conferences and there are aHUS conferences, this is the first one, I think, that's married the two.
Len, thank you very much. So I wanted to try to get out from Len there and continue to communicate to you that this is an iteration. When I first met Len, it was just intriguing to me how much experience he had with the disease state already and how knowledgeable he was. And I think that's where we are in 2017 with patients that have the disease. There are a number of networks that are available. If they want to reach out and they want to know more about the disease, there are a number of venues and channels that they can use in order to find out more. And so I want to reinforce the format that we're going to use today. You should have agendas on your tables. If you don't, we can certainly pass them around. But recognize that nearly for every talk, there's a patient perspective which is going to lead in to that talk. And so as compared to some earlier meetings where there's a panel discussion or question and answer at the end of the day for the patients, we're really incorporating the patient perspective throughout this meeting. So certainly something different that I have not experienced previously. Again, recognize that we're just going to be moving straight through, so the lunch break here is really going to be while Dr. Francis is talking. So. The folks that are in attendance. The number of people that have responded to us and we've been interacting with a variety of perspectives, certainly patients, family members as well. So family members that perhaps know that they have a mutation in the complement system but have not presented with the disease, they're here too. Certainly physicians. There are some residents in training that potentially will be here as well, nurses and researchers as well from the basic science side. So really an amalgam of people that I think need to be talking to each other, and hopefully this is the platform which is going to really spearhead that kind of dialogue. Recognize that, and this is coming from the side of the physician, and what we're trying to do is again meld the perspectives of the patient so that the physician recognizes what the patient perspective is on a first-hand basis, but at the same time so that patients that are here as well as those that are going to be listening and watching later can recognize what the physicians understand and how they perceive the patient diagnosis as well as overall continuance with treatment of the disease. So from the physician side, as Dr. Bonventre had mentioned earlier, we recognize that this is really endothelial based. Certainly some vascular biologists will focus on the bloodstream itself and what's circulating in the system, but the nidus, which initiates a lot of this disease, is endothelial origin. I think there can be some debate about that, and certainly healthy debate. But as to how that endothelial cell ultimately gets injured, there's a number of different scenarios which we as physicians are trying to identify were ever present inside of the history. Too many times when we're enrolling people inside the aHUS registry, we try to identify what was the presenting symptom, and it was a viral illness. It was diarrhea, a gastroenteral virus, or it was pregnancy. So it can be somewhat deceptive as to what the ultimate diagnosis is, and what initially comes on simply as a common cold or an upper respiratory infection can really be striking and shocking to that patient that develops renal failure and an ultimate diagnosis of aHUS. Because the diagnosis itself can be so difficult to identify, it really takes a network of physicians working in consort to be able to identify what's going on. Not all the time is renal failure involved. Hematology, often the folks that are initially consulted as a result of concern for mortality associated with other TMAs, and not simply aHUS, and certainly TTP is what's invoked very, very frequently. But obstetricians, they sometimes are the first people that actually identify a manifestation of disease. Earlier and earlier, we're dealing with some very rare presentations that are really the only identified after discrete and very particular analysis by geneticists. Dr. Cree will be describing that in just a little bit, a very interesting family presentation. But then again, the intensivists, the ICU physicians, are often physicians that we're dealing with that are identifying a fulminant manifestation of disease, a much less subtle presentation as compared to, say, proteinuria in a patient with preeclampsia. So a variety of physicians involved, a variety of manifestations is what we see as physicians. On the patient side, what I've come to recognize after speaking with Len Woodward and Linda Burke and a number of others in detail on conference calls, as well as just going through some of the information that's logged on the internet, is really how detailed the patients are nowadays in identifying what is going on, what are they feeling. What we understand that to be as physicians is clinical manifestation of disease. That's in the history portion of our history and physical. How are you feeling today? It's much less important in that scenario to know what their creatinine is, what their platelet level is. It's how are you affected? And the aHUS Alliance has been instrumental in manifesting what the patient can provide when it comes to how they feel as a result of the disease, prior to the disease, after treatment, and whether or not treatment is really efficacious. It's one thing to treat a number, it's another thing to treat a patient. What I've also recognized by efforts of Linda Burke, especially when it comes to internet access and really broadcasting globally, is the international need. Len had mentioned this, the number of societies or groups or patient advocacy groups that are involved now. Linda will talk about this a little bit more at the end, but each one of these emblems recognizes a different group from a different country that is associated with patient advocacy related with aHUS. It's just remarkable how many groups have demonstrated a need and are reaching out and really speaking as a single voice. I recognize again that, again, it's September 24th is aHUS Awareness Day. Look at this website if you have a chance. Really interesting stuff inside there from the perspective of a physician. There's some live cell imaging that they recognize, or that they are showing there to demonstrate to patients what their blood vessel looks like subsequent to complement activation versus prior to complement activation. Some pretty high-tech data which is being shown directly to the patients, and I think it's in a format that is understandable as well. So all of that being said, again, there is a lot that the physicians are aware of today about aHUS that they were not aware of in 2010 or in 2009. But I think it needs to be emphasized just as much that there is a significant knowledge base that patients with aHUS and family members that have patients with aHUS have. And it is remarkable how knowledgeable this group of patients is about their disease.